Here we have a coronal CT through the temporal bone. The external ear or pinna is seen here, opening up to the external auditory canal right here. The external auditory canal consists of an outer fibrocartilaginous portion here and an inner bony portion seen here. The narrowing we see in the external auditory canal as we transition from fibrocartilage to bone right here is known as the isthmus. You'll notice this point of narrowing persists as I scroll anteriorly. Right here is the isthmus. Medially, the external auditory canal is bounded by the tympanic membrane right here, seen as a faintly visible line extending from the scutum above to the tympanic annulus below. The little scoop of bone right here, just before the tympanic annulus, is called the tympanic sulcus. This is the tympanic sulcus, and this is the tympanic annulus. Behind the tympanic membrane is the middle ear cavity. The middle ear cavity consists of the epitympanum, mesotympanum, and the hypotympanum. The epitympanum is everything above a line drawn between the scutum and the tympanic segment of the facial nerve right here. So this line delineates the inferior boundary of the epitympanum. The epitympanum contains the head of the malleus, seen here, as well as the body and short process of the incus. This is the incutomalleal joint, which is a synovial sliding type joint, seen here. If I scroll posteriorly, I'll see the short process of the incus going posterolaterally back here to the fossa incutus right here. Scrolling back anteriorly, another important area is the anterior epitympanic recess, which is just anterior to the cog. We'll see this better on axial view, but it will generally be in this area right here, anteriorly. Scrolling back posteriorly a little bit, we see an important ligament right here attaching to the neck of the malleus. This is the lateral mallear ligament. This forms the superior border of Prusac space. Prusac space is just above the scutum and below the lateral mallear ligament, and is therefore a very small space in this area. Cholesteatomas tend to arise in this area, so you should look for a soft tissue density here and look for erosion or just blunting of the scutum to suggest cholesteatoma as a possible diagnosis. You'll also notice on this slice that we're starting to transition down to the mesotympanum as we go from the neck of the malleus to the manubrium and then umbo. These portions of the malleus will articulate with the tympanic membrane right here. We also see the tensor tympani tendon right here as it goes toward the malleolar neck right here. Scrolling posteriorly now, we see the body of the incus, and then we'll see the long process of the incus right here going down into the mesotympanum and bend sharply to get to the lenticular process. The lenticular process of the incus will articulate with the capitulum or head of the stapes right here, which then goes to the neck of the stapes and then into anterior and posterior crura, and finally to the footplate of the stapes. The footplate of the stapes is the part that articulates with the oval window right here. We'll see these structures again on axial CT. The hypotympanum is everything below a line drawn between the tympanic annulus here and the cochlear promontory here. None of the ossicles are down here in the hypotympanum. We'll now review these on axial CT. Here on axial CT, through the temporal bone, we see the external auditory canal right here, narrowing slightly at the isthmus as we transition from fibrocartilage to bone. The bony portion of the external auditory canal is formed largely by the tympanic segment of the temporal bone, which forms its anterior, inferior, and posterior walls. The superior wall will be formed by the squamosal portion of the temporal bone. Scrolling superiorly now, the tympanic membrane is right here, forming the medial wall of our external auditory canal. This here is a tympanic portion of the temporal bone, with the medial portion here completely intact. I mention this because sometimes there can be a defect here with protrusion of contents from the glenoid fossa backwards. This is called a foramen of Huschke, and is pathologic if it is present beyond the age of 5. You'll also notice this little cleft here known as the squamotympanic fissure. It is also sometimes called the glissarian fissure, and is the course through which the chorda tympani must pass to get to the glenoid fossa. Sometimes it's also called the mandibular fossa because the mandibular condyle is right here in it. The squamosal portion of the temporal bone has a zygomatic process going up here to articulate with the zygoma, and medially it has the sphenoesquamosal suture where it's articulating with the greater wing of the sphenoid bone. The greater wing of the sphenoid bone here shows the foramen ovale, and posterolateral to it you have the foramen spinosum right here. Let's look at our middle ear cavity in greater depth now. If I scroll a little bit more superiorly, I'm going to pass through the hypotympanum and get to my mesotympanum right here, and a little more superiorly yet, I'll reach the epitympanum here. Now I mentioned a subspace of the epitympanum called the anterior epitympanic recess. That is right here, anterior. Specifically, it is anterior to this bone, which is coronally oriented here, called the cog, C-O-G. The cog separates this space and is of significance because if pathology gets through here, it can be particularly hard to reach. You'll specifically need a middle fossa, craniotomy, in order to get to lesions in this area. Also, if you get a cholesteatoma here, it can cause impingement of the facial nerve. Medially, we'll notice the facial nerve is passing right next to it. Here's the geniculate ganglion, and here is the tympanic portion of the facial nerve coursing posterolaterally right here. Let's look at our ossicles again, starting with the malleus. The head of the malleus here is articulating with the anterior facet of the body of the incus. This is called the incutomalleal joint right here. If I follow the body of the incus and watch it become the short process as I scroll inferiorly, we'll notice it goes into this little subsection of the epitympanum called the fossa inculatus back here. I'm going to scroll more superiorly again, and we're going to watch the malleus. Now the malleus, as I scroll inferiorly, will become the neck right here. The neck of the malleus I mentioned earlier will be in contact with the lateral mallear ligament right here, which forms the superior boundary of Prusac space. Also, medially, it has another important attachment to the tensor tympani tendon right here. The tensor tympani tendon comes off of the cochleariform process here to get over lateral to reach the mallear neck. If I scroll further inferiorly, I'm going to be at the level of the manubrium, which is here, and it articulates with the tympanic membrane, and way down here is the umbo of the malleus. Let's go superiorly one more time, and we're going to follow the incus. So here, we're going to get to the level of the body of the incus, and I'm scrolling inferiorly to get to its long process right here. You'll notice we're posterior to the malleus. So the long process is here, and as I scroll inferiorly, it's going to bend right here, and then articulate with its lenticular form process with the head of the stapes, also known as the capitulum. The stapedius tendon is going to attach at the neck of the stapes, and then we're going to have anterior and posterior crura getting to the oval window over here at the foot plate. If I continue a little bit more inferiorly, we'll see this. And then we're also starting to see this large protrusion off the basal turn of the cochlea here. This is called the cochlear promontory. The cochlear promontory is interesting because it has a superior and inferior bony projection called the ponticulus and the subiculum respectively. So let's look superiorly at our cochlear promontory by going back up. So up here is the top part of our cochlear promontory. And you'll notice right here there's a little bony spicule. This is called the ponticulus. Behind it is where we see the sinus tympani. Now I'm going to scroll inferiorly. You'll notice it's totally open right here. But down here, coming off the cochlear promontory, there's again a bony projection right here. This is called the subiculum. So the ponticulus and subiculum help form boundaries, posterior to which is our sinus tympani. Now you'll notice here when we're at the level of the subiculum, it's also forming the posterior boundary of the round window niche right here, which is going to be important for articulation with the scala tympani over here. Here on sagittal CT, we can view these same structures. Our round window niche is seen right here, going up to the level of the round window above. Posteriorly is our subiculum. As I scroll laterally, we see the subiculum in continuity with the cochlear promontory, and we see an additional bony projection coming superiorly off the cochlear promontory called the ponticulus. As I scroll laterally, we see that the ponticulus above and the subiculum below form a partial anterior wall covering this space. This is called the sinus tympani. As I scroll further laterally, we see the pyramidal eminence right here with a soft tissue attenuation structure within it representing the stapedius muscle. As I go further laterally now, we see the facial recess right here, which will run right next to the facial nerve. Here's the mastoid segment of the facial nerve, which is the specific component next to the facial recess. And as I scroll further laterally, we see this additional canal coming off of the mastoid segment of the facial nerve for the chorda tympani. The chorda tympani exits the mastoid segment and goes into the middle ear cavity right here, and then it will exit the middle ear cavity by going through the squamotympanic or glycerian fissure right here. As I scroll further laterally, we're going to pass through our tympanic membrane and get to our external auditory canal, including the bony and then fibrocartilaginous portions, which will lead out to our external ear or pinna right here. Let's go back and review our inner ear structures again. So here, we're going to be back at our round window niche and the vestibule. The semicircular canals come off the vestibule, and first we'll review the lateral semicircular canal, also known as the horizontal semicircular canal. Here it is posteriorly, and as I scroll Laterally once more, we're going to see this lateral semicircular canal connects to its anterior component here, and then go back to the vestibule right here. Here's our superior semicircular canal, which I can scroll medially to see the full extent of. The bony impression it makes right here is called the arcuate eminence. It's important to make sure that this is all intact to rule out dehiscence of the superior semicircular canal. Here we see it connecting posteriorly and reaching this structure called the common crus. It's called the common crus because it shares the connection with the vestibule with the posterior semicircular canal, which we see coming off right here. As I scroll a little more laterally, here we see our posterior semicircular canal coming back here, and now I'm going medially once again to see it connect to the vestibule. Next, let's go ahead and review our cochlea. So our cochlea has 3 turns. The basal turn is right here, with an impression forward right here forming the cochlear promontory. The modiolus is the bony structure in the middle. Here's our middle turn of the cochlea, and here's our apical turn up here. The modiolus allows for interscalar septa to separate each turn of the cochlea. So you have interscalar septa here between the basal and middle turns, and interscalar septa, which are harder to see right here, between the middle and apical turns. Let's go ahead and turn now to our axial CT images to review these same structures. Here again on axial CT, we can see our cochlea with its basal turn right here. An interscalar septum here divides it from the middle turn, and as I go further superiorly, we'll see the apical turn divided away from the middle turn by this additional interscalar septum. The interscalar septae will all converge on the modiolus, which is the central bony structure seen here. Because the apical turn does not make it around 360 degrees, in total, our cochlea only has between 2.5 and 2 3/4 turns. Scrolling back inferiorly now to our basal turn, the cochlear promontory is this bony ridge right here, overlying it, and down here is our round window niche. As I scroll a little more superiorly, we'll reach our oval window right here, where we can see the anterior and posterior crus of the stapes coming down upon their footplate. Just anterior to here, there's a little cleft called the cochlear cleft or fistula antefenestrum. When there is lucency in this area, the patient has fenestral otosclerosis. And if the lucency is spread around the cochlea, then they have retrofenestral otosclerosis. When it's just limited here, then you can get fixation of the stapes footplate, causing conductive hearing loss in fenestral type otosclerosis. But when it gets retrofenestral, then you can also have sensorineural hearing loss. Scrolling superiorly now, we're going to reach our internal auditory canal right here, and the vestibule here. The lateral or horizontal semicircular canal is seen here. As I scroll superiorly, we'll see our superior semicircular canal with its anterior and posterior limbs, converging superiorly right here. The bone here is called the arcuate eminence. Coming back down now, we're going to watch the subarcuate foramen go right between these two limbs, the anterior limb and posterior limb of our superior semicircular canal. This is the subarcuate foramen, and it carries the subarcuate vessels. The most important thing to recognize is that this is a normal structure and does not represent a fracture. Scrolling further inferiorly, we're going to see the posterior semicircular canal converge with the posterior limb of our superior semicircular canal. Below this point, it's therefore called the common crus, and here we see the common crus coming down into the vestibule right here. Watching our posterior semicircular canal, we'll watch it get a little more inferior than the others and come down this way and then head anteriorly and back superiorly. So now I'm going to scroll superior a couple slices and see it get back to the vestibule. Now we can also see connections between our internal auditory canal and our vestibule, since you do have to have the vestibular nerve branches get over here to do their jobs. So first, right here, the superior vestibular nerve crosses through to get to the utricle. As I get a little more inferiorly, we're going to see another opening right here that's very subtle for the inferior vestibular nerve to get to the saccule. One more opening right here is called the cingular canal and will transmit the posterior vestibular nerve to the ampulla of the posterior semicircular canal back here. Now let's also look right here at this opening in the petrous bone called the vestibular aqueduct. It opens here to the operculum. If this measures greater than 2 millimeters, it represents an enlarged vestibular aqueduct, which can be seen in sensorineural hearing loss. Additionally, if a midpoint between here and the vestibule or posterior area of the vestibule or common crus measures greater than 1 millimeter, so about in this area, then that would also be an indication of possible sensorineural hearing loss related to an enlarged vestibular aqueduct. Scrolling a little more inferiorly now, I'll draw your attention to another opening seen right here. This is called the cochlear aqueduct. The cochlear aqueduct carries perilymph from the scala tympani through the petrous portion of the temporal bone into the CSF of the posterior cranial fossa.
So just lateral to it will be this jugular bulb, and if I go inferiorly, just inferior to it, we'll have the carotid canal. Let's talk briefly about the mastoid air cells now. Here are the medial mastoid air cells. If I get more superiorly, I'm going to see that there are lateral and medial mastoid air cells, which are divided somewhat by the petrosquamous fissure, which continues posteriorly here as the Kerner septum. The Kerner septum will act as a relative barrier for spread of effusions from the lateral to the medial compartments of the mastoid air cells. Additionally, it forms the anterolateral wall of the adductus ad antrum and the mastoid antrum. The epitympanum communicates with the mastoid antrum through this area called the adductus ad antrum, which is Latin for access to the cave. So now, the internal auditory canal has a lot of nerves transmitted through it that we honestly need to look at on an MRI. And in fact, we're going to now review several cranial nerves as they go through the cisterns around the brain, and then we'll focus in again on our facial, vestibular, and cochlear nerves in this region. And we'll use a steady-state free precession sequence to do this review. This is an axial steady-state free precession sequence through the brain. We're at the level of the midbrain and right and left cerebral peduncles. The fluid-filled structure back here represents the cerebral aqueduct. As I scroll inferiorly, I'll notice portions of the hypothalamus here, and the fornices as they converge inferiorly as the right and left mammillary bodies. This is the posterior cerebral artery, and here is its contralateral companion, the left posterior cerebral artery. These, of course, represent the terminal branches of the basilar artery seen here. As I scroll inferiorly, I'll notice this cleft of CSF growing and forming the interpeduncular cistern right here. It is from the interpeduncular cistern that the oculomotor nerves arise. This is the right oculomotor nerve. It's going to course anterolaterally, like so. You'll notice it has a unique position, just inferior to this posterior cerebral artery above, and just superior to a superior cerebellar artery right down here. Because of its positioning between the posterior cerebral artery above and the superior cerebellar artery below, it is at risk of impingement when there are pathologies in these vessels. Likewise, the trochlear nerve, which comes off the dorsal brainstem, back here, courses right between these two vessels and may likewise be affected by aneurysms or other pathologies in the posterior cerebral artery or superior cerebellar artery. As I continue to scroll inferiorly, I'm going to reach the level of the trigeminal nerves, which are these very large nerve bundles here and here. They're coming off the pons and crossing the prepontine cistern. The prepontine cistern is this CSF space right here. After they pass through, they go through the Meckel cave right here, also known as the trigeminal cave. They have large sensory components medially and motor components laterally. As I continue to scroll inferiorly and watch the basilar artery, we'll see it give rise to an important vascular structure right here. This is the anterior inferior cerebellar artery, which is going to course posterolaterally back here, next to the porus acousticus back here. Cranial nerve 6, the abducens nerve, can also be seen down here, coming off the inferior pons. The abducens nerves are going to course anteriorly through the prepontine cisterns and enter the durello canals here and here. As I continue down, I'm now at the level of the cerebellopontine angle cisterns. It is off the inferior aspect of the pons here that cranial nerve 7 and 8 will arise. They are nearly parallel in their course through their cisternal segments as they cross the cerebellopontine angle cisterns, and they stay nearly parallel to one another as they course through the porus acousticus here and enter the internal auditory canals here and here. As I scroll a little more inferiorly, I'm going to notice an important lobe of the cerebellum. This right here represents the floccular lobe. It separates cranial nerves 9 through 12 below from the other cranial nerves which we've discussed. As we scroll more inferiorly, we'll notice the jugular foramen right here. It is through this that the glossopharyngeal, vagus, and accessory nerves will course. The glossopharyngeal nerve is the most anterior and superior of these nerves and is going to course right here through its cisternal segment to enter the jugular foramen. As I get a little more inferiorly, we'll see the branches of the vagus nerve come off the posterolateral sulcus, and they will likewise enter the jugular foramen. As I continue to scroll down, I'm going to notice additional branches that come off of the medulla, plus some that come all the way down off of the cervical portion of the spinal cord down here. The accessory nerve, cranial nerve 11, has components coming off the cervical cord right down here, which go through the foramen magnum and converge with additional intracranial rootlets. They stay behind the vertebral artery right here and make their way superiorly and get through the jugular foramen. They course more inferiorly and posteriorly than do the glossopharyngeal and vagus nerve roots. Finally, one more cranial nerve is cranial nerve 12. The hypoglossal nerve comes off of the medulla right here and is going to course into the hypoglossal canal right here.
Cranial nerves 7 and 8 are of particular clinical importance and can be followed as they course through the internal auditory canal on sagittal oblique imaging as seen here. This is a T2 weighted sequence with the pons seen here and the medulla below. The structure right here represents the middle cerebellar peduncle. The cerebellopontine ankle is right here, and as I course laterally, we can watch the facial and vestibulocochlear nerves arise from the cerebellopontine angle, cross the cerebellopontine angle cistern, and then enter the porus acousticus right here. As I get further laterally, the nerves break up into more discrete fibers until I'm at this point. Here anteriorly and superiorly, we have the facial nerve. Anteriorly and inferiorly, we have the cochlear nerve. Posteriorly, we have the superior and inferior vestibular nerves. There's a bony crest called the crista falciformis that divides the internal auditory canal, right here, into superior and inferior halves. Another bony landmark is the bill bar, which splits the anterior and posterior internal auditory canal along its superior aspect right here, separating the facial nerve from the superior vestibular nerve. On coronal CT, the internal auditory canal is right here. Laterally, the falciform crest is right here, separating the internal auditory canal into superior and inferior halves. The bill bar is another bony spicule, which is very hard to visualize, that separates the superior portions of the internal auditory canal into anterior and posterior quadrants. Scrolling further anteriorly, I am now in the anterior superior quadrant of the internal auditory canal, where the facial nerve resides. The canalicular segment of the facial nerve is here, and as we go further anteriorly, it will go into the labyrinthine segment right here. Following it further anteriorly, I'll reach the anterior genu, right here. This is where the geniculate ganglion resides. The greater superficial petrosal nerve will extend further anteriorly yet from this geniculate ganglion and enter the hiatus of the facial canal to enter the middle cranial fossa. From there, it will pass through the pterygoid canal or Vidian canal, where it will join up with the deep petrosal nerve. But let's follow the tympanic segment of the facial nerve, which comes off here and then goes posteriorly. Here I'm scrolling posteriorly to follow the tympanic segment of the facial nerve. I watch it go just inferior to the horizontal semicircular canal right here. Scrolling further, I'm going to reach the point where it gets to a posterior genu back here and then goes into the mastoid segment right here. The mastoid segment of the facial canal goes down this way into the stylomastoid foramen here. This opening right here houses the chorda tympani. The chorda tympani courses superolaterally and anteriorly. So here I'm scrolling anteriorly again to watch this extra canal housing the chorda tympani, and I'll watch the chorda tympani enter the middle ear cavity right here, just behind the tympanic membrane right here. As I go further anteriorly, I'll notice it enter the mandibular fossa by passing through the glossarian or petrotympanic fissure right here. We can also follow the course of the facial nerve on axial CT. Here's our internal auditory canal, and the labyrinthine segment of the facial nerve is right here. Scrolling down one slice, I see the anterior genu, or geniculate ganglion, which gives rise to the greater superficial petrosal nerve. Remember, the greater superficial petrosal nerve will course anteriorly into the middle cranial fossa, and as I scroll inferiorly, we'll find the Vidian canal way down here. This is where it joins up with the deep petrosal nerve. Let's scroll back up to the level of our geniculate ganglion. So that'll be way up here. This is where the tympanic segment of the facial nerve will also start coursing posterolaterally. So scrolling slightly inferiorly, we'll see the tympanic segment right here as it courses posterolaterally. Here it reaches the posterior genu, whereupon it becomes the mastoid segment, which courses inferiorly to enter the stylomastoid foramen way down here. At the skull base, we should also pay close attention to the carotid canal and the jugular fossa, and we will now discuss additional nervous structures which course through the temporal bone.
Here is the carotid canal. Down below is the jugular bulb. As I scroll posteriorly, I'm going to notice an opening in the jugular bulb right here. This is the inferior tympanic canaliculus. The inferior tympanic canaliculus creates a communication between the jugular bulb here and the middle ear cavity right here. You can see it connecting up at this point. Going back anteriorly, let's talk about the structures that course through the inferior tympanic canaliculus. These will include the Jacobson nerve, which is a branch of cranial nerve 9, the glossopharyngeal nerve, and also the inferior tympanic artery. The inferior tympanic artery is a branch of the ascending pharyngeal artery, which in turn came from the external carotid artery. Scrolling more posteriorly, we'll see another important opening in the skull base that is going to be at the level of the mastoid segment of the facial nerve. This little opening right down here is known as the mastoid canaliculus. It's probably named the mastoid canaliculus because if you go anteriorly a little bit, you'll notice it's connecting up into the mastoid segment of the facial nerve. This canal, known as the mastoid canaliculus, will transmit Arnold's nerve, which is a branch of cranial nerve 10, the vagus nerve. I mentioned Arnold's nerve here, and Jacobson's nerve, which we saw a little more anteriorly, right, going through the inferior tympanic canaliculus together, because each of them can give rise to paragangliomas. Specifically, each can give rise to a glomus jugulare tumor. Additionally, Jacobson's nerve can give rise to a glomus tympanicum because of its course over the tympanic membrane. So when you see a soft tissue density over the cochlear promontory right here, it may be related to a Jacobson nerve tumor known as a glomus tympanicum. Now let's identify these same structures on an axial CT through the temporal bone. The carotid canal is right here and is separated from the jugular bulb by this carotid-jugular spine. It is this structure which we should pay close attention to, as the inferior tympanic canaliculus will arise from it as we scroll a little more superiorly. Here I am scrolling up, and now we see this little opening developing off the jugular bulb that seems to be right on the carotid-jugular spine, right here. Scrolling a little further up, we see it right here and can see it enter the middle ear cavity more laterally. This again will house the Jacobson nerve as well as the inferior tympanic artery. Now let's look more laterally. This is the mastoid segment of the facial nerve right here. As we scroll further superiorly, we'll notice the full extent of this mastoid segment of the facial nerve. And up here is where it is the tympanic segment. So this posterior genu part, where it bends downward, is where the mastoid segment of the facial nerve begins. So we're going to look very carefully along the medial aspect of this to find the origin of the mastoid canaliculus. So I'm going to scroll down again. Scrolling down, we're going to see this little branch of a nerve representing Arnold's nerve coming off a canal right here. This is the mastoid canaliculus. So let's continue to follow it down, and we'll notice that it's going to get down to the skull base down here.
Contrast-enhanced MRI through the internal auditory canals with fat suppression will allow us to look for abnormal enhancement of the facial nerve, as may be seen with Bell's palsy or sometimes in Ramsay-Hunt syndrome. Here we're starting inferiorly at the level of the carotid canal seen here, and the jugular bulb posterolateral to it right here. Scrolling superiorly, we'll pass by the cerebellar flocculus here, and see the cerebellopontine angle cistern right here, through which cranial nerves 7 and 8 will cross to get to the porus acousticus. You'll notice there's no enhancement of the cisternal, canalicular, or labyrinthine segments of the facial nerve. This is normal. There is an enhancing dot here representing the geniculate ganglion at the anterior genu. As I scroll a little more inferiorly, I'll see the tympanic segment enhancing, which may or may not happen in normal cases. As I scroll more inferiorly, we'll reach the mastoid segment of the facial nerve here, and see it continue to enhance more inferiorly as it exits through the stylomastoid foramen. In a study by Hong et al. Published in the British Journal of Radiology in 2010 entitled Enhancement Pattern of the Normal Facial Nerve at 3T Temporal MRI, they found 100% of cases they reviewed had mastoid segment enhancement, whereas 37.5% had tympanic segment enhancement. More superiorly, the anterior genu enhanced in about 78% of cases, the labyrinthine segment in 15% of cases, and the canalicular segment in 5%. If you're assessing for Bell's palsy in the correct clinical setting, make sure to look not only at the enhancement pattern of these segments, but also to look contralaterally to see if there is abnormally increased enhancement on the side affected.